Let's talk about medicine updates 2023. These are the most recent advances that has happened in medicine. So in the dyspnea, now we have a POCUS scoring that helps in detection of heart failure, pulmonary embolism, pneumonia, pleural effusion, and pneumothorax. It is seen that in dysuria, D-mannose is protective against recurrent UTIs. Now, geriatric disorders, we have a chronic fatigue syndrome. In chronic fatigue syndrome, there has been a recently discovered H3 receptor antagonist, which is a pitolisant. It has a wake promoting effect. It reduces the daytime sleep in the patients with patients with moderate to severe obstructive sleep apnea. Who do not want to continue a positive airway pressure. For them, pitolisant is like a dream come true. Then for the patients with dementia, earlier we used to have a rivastigmine, galantamine, and tacrolimus, but now we have a monoclonal antibodies that is aducanumab. It is protective against amyloid beta proteins. They form a monoclonal antibody against it. After this, we have in pulmonary disorders. In bacterial rhinosinusitis, we have a monoclonal antibodies against interleukin 4 and interleukin 1, that is dupilumab, and it is approved for chronic sinusitis with nasal polyposis. Now for ABPA, we have some newer drugs. We have anti-IgE omalizumab that is also used in bronchial asthma. Then we have anti-interleukin 5, mepolizumab and benzalizumab. Then for we have dupilumab as anti-IL-4. So how we remember is like A, B, C, and D. D comes at fourth position, so IL-4. IgE, we have omalizumab, and for IL-5 we have MB, mepolizumab and benzalizumab. After that, we have screening for lung cancer. Nowadays, it has been recommended to use a low dose CT in the patients of high risk patients to screen for the lung cancer. Who are the patients who are at high risk? Who smoke at least 20 pack per year. Uh, Patients who smoke 40 pack per year are at a highest risk of lung cancer, but these are the patients who have to undergo a screening. 20 packs per year, age 50 to 80 years, current smoking, and quit date within past 15 years. It should be stopped, screening should be stopped once a quitting period has exceeded more than 15 years. Now, there's a term known as chronic stable angina pectoris or a chronic coronary syndrome. For this, it has been advised to use a CT functional fractional reserve to look at the prognosis of a disease and to see whether the patient needs revascularization or not. Then in heart failure, we know ARNI has been a boon in heart failure, but now it has been seen that along with the reduced ejection fraction, it can also be given in a preserved ejection fraction. Then a lot of trials had been on SGLT2 inhibitor, that is empagliflozin, and they has shown a improved benefits even with the patients without diabetes. Now, for the prevention of primary and secondary cerebral vascular diseases, aspirin has been recommended for the primary prevention in the patient from 40 to 49 years, and patients who are above 60 years, aspirin should not be initiated for the primary prevention. That as it can lead to higher risk of GI bleed, higher risk of GERD and gastric ulcers. So it is not recommended in the patients above 60 years of age. Nowadays, it has been seen that a patient is advised a home-based PP monitoring for the diagnosis of hypertension. So aortic dissection. Earlier, we have seen that in aortic dissection, the drug of choice has been the beta blocker, but the patient whom we cannot give a beta blocker can be given a IV calcium channel blocker, that is nicardipine at 5 mg per hour. Then we have occlusive diseases of a femoral and a popliteal atherosclerosis. Earlier, we used to give aspirin or low molecular weight heparin, but nowadays dual treatment can be given with rivaroxaban and aspirin. Rivaroxaban 2.5 mg BD and aspirin 81 mg orally daily, and in India 75 mg. In plasma cell myeloma, it has been seen that there is a chimeric antigen BCMA that show a response rates of more than 70% when given over 11 months. Then Antithrombotic therapy and primary venous thromboembolism prevention. We'll see what it is. Earlier, for the disorders of hemostasis or thrombosis, dual and oral anticoagulants were recommended, but now dual oral anticoagulants are not recommended. Rather, in the patient who are morbidly obese, ebicexiban or rivaroxaban is chosen rather than dabigatran or edoxaban. Heparin may be preferable as an initial treatment in the hospital, and then at the discharge you put the patient on abiraxaban or a rivaroxaban. So for the patients who are the COVID-19 with primary venous thromboembolism with higher values of elevated D dimers, we should give a supplemental oxygen to the patients, and therapeutic anticoagulant should only be given to a high risk patient. To the low risk patient, only oxygen is sufficient. GI disorders. For the acute diarrhea, we have seen the treatment is basically according to the severity, and we add ORS, we add zinc in the patients who have a no motility disorder. We can add a loperamide, or if the patient is having fever, we add a metronidazole or fluoroquinolones. Now, what they are saying in severe diarrhea or in a dysentery, or the patient who is a known case of IBD or immune checkpoint, he is on an immune checkpoint inhibitor. In these, after doing a sigmoidoscopy and colonoscopy and ruling out infection, IV corticosteroids can be given. For the patients who are a Shiga toxin producing E. coli, they should never be given antibiotics as it increases the risk of hemolytic uremic syndrome. In anorectal infection, it has been seen that to detect gonorrhea and chlamydia, we should go for a nucleic acid amplification technology. In the chronic diarrhea, uh, what is strongly predictive of a bile acid diarrhea is elevated fasting levels of bile acid more than 48 nanogram per ml. In GI hemorrhage, we have seen that we do a endoscopy and see that the hemorrhage is due to what. So it is seen that during the endoscopy, we can put a topical powder that is known as hemospray that can provide a temporary homeostasis of for 24 hours, and for the temporarily bleeding can be stopped, and then after 24 hours you can go for an endoclip placement over there. Then in the IBDs, in the inflammatory bowel disease, there has been a discovery of the new drug that is known as ozanimod for moderate to severe ulcerative colitis. In IBS, it has been seen that peppermint oil is extensively being used, and it is of a very good clinical importance as it reduces abdominal pain and it reduces flatulence. It has been added in the newer edition of Harrison as well. Other primary motility disorder, it has been seen that opioids should not be given as they exacerbate the esophageal dysmotility. Now, for peptic ulcer disease, earlier we used to, go for uh, invasive tests. Nowadays, invasive tests are not done, and rapid tests are done. And now there are commercial laboratories that offer a culture-based and molecular-based susceptibility testing for H. pylori before starting of empirical treatment. In Zenker diverticulum, minimal invasive intraluminal approaches are being developed, such as which can replace a craniopharyngeal myotomy. Now, in hyperkalemia, we all know the treatment of hyperkalemia, that you add a calcium gluconate, you add insulin in D50, then you give furosemides, you give these albuterol and salbutamol, you undergo a dialysis. Now, there has been extensive use of patiromer and sodium zirconium cyclosilicate in acute hyperkalemia. In hyperkalemic emergency, even sodium zirconium cyclosilicate is preferred due to its more rapid onset. So nowadays, this is a newer drug, sodium zirconium cyclosilicate. It comes from the name of SZC. Now, for the patient of cirrhosis with portal hypertension, earlier we used to give beta blockers as propranolol, but nowadays it has been seen that you should give a non-selective beta blocker with the alpha 1 blocker, that is carvedilol. It reduces the frequencies of decompensated events. Vancomycins can be added in the patient of spontaneous bacterial peritonitis. If the patient is vancomycin resistant, you can add a daptomycin, and for the patient who have recently been exposed to peptides, we can add meropenem to such patients. For non-alcoholic fatty disease, the diagnosis criteria is the diagnosis of exclusion. So we should also go for a non-invasive testing for the fibrosis. That is, you should go for a FIB-4 score. For FIB-4 score, you need age, you need a platelet count, AST and ALT levels. Similar FIB-4 score is also done for hepatitis B infection. For hemochromatosis, the serum biomarkers for fibrosis are elevated plasma iron with transferrin levels more than 45%, low unsaturated iron binding capacity, and very high serum ferritin. For primary biliary cholangitis, obeticoic acid is given. It is a pherinoid X receptor agonist, but this has been discontinued because of higher chances of serious liver injuries. For breast cancer, we have some newer drugs. One is a BRCA1 and 2 antagonist, that is olaparib. Then we have edema-ciclib. Then we have for HR positive disease. For stage 2 or a greater triple negative breast cancer, we have pembrolizumab. Then for the CDK4 and 6 inhibitor, we have palbociclib, ribociclib, and abemaciclib. Then for the treatment of BRCA associated metastatic breast cancer, we have olaparib and talazoparib, that is PERP inhibitor. Now, intrauterine devices, levonorgestrel 52 mg can be inserted within 5 days of intercourse, and it is a protector. It plays a protective role against conception. Then in pelvic inflammatory disease, we have always been using ceftriaxone. So in outpatient department, we add a ceftriaxone 500 mg IM or 1 gram. We add a doxycycline 100 mg BD for 14 days. We add metronidazole 500 mg BD. Or you can give us cefoxitin, probenecid, doxycycline, and metronidazole for the same. It has been seen that in a complex regional pain syndrome, vitamin C plays a preventive role. For gonococcal arthritis, the treatment of choice is parenteral ceftriaxone. After the susceptibility testing has been done, and if it is susceptible if it is not resistant to ceftriaxone, it should be continued. And after discharge, the patient should be put on an oral agent for next 7 days. So for the patients with granulomatous with polyangiitis, we know the drug of choice is rituximab. We can also add immunosuppressant cyclophosphamide. Newer FDA-approved drug that works against ANCA is avocopan, which can be an add-on therapy to the corticosteroids and the cyclophosphamide, or to the rituximab with corticosteroids. In non-severe disease, methotrexate can be put up to 25 mg. Rituximab dose is 1 gram every 6 months or 500 mg every 4 months is a favored first-line management. So for the granulomatous polyangiitis, you have to add a rituximab, or you can add a cyclophosphamide, or you can add a corticosteroids with cyclophosphamide, corticosteroids, and there's a newer drug that is known as avocopan. You can add that. In cases where the patient is in a non-severe state, you can also give a trial of methotrexate. If you are adding a rituximab, the dose is 1 gram every 6 monthly or 500 mg every 4 monthly. For polyarthritis nodosa, high dose pulse therapy with methylprednisolone should be given. For relapsing polychondritis, we have a Vaxas, that is Vacuols, E1 enzyme, X-linked auto-inflammatory somatic disease. They have a mutation against UBA1. Then what are the clinical features? They have a hematological manifestations. Then there's a chondritis, as the name suggests, polychondritis, chondritis, vasculitis, fever, and arthritis, and it is X-linked. And rheumatoid arthritis, we know that rituximab reduces a humoral immune response. It has also been used with a caution in COVID-19, but it has been shown that use of rituximab in COVID-19 has shown a higher risk of mortality. Now, SLE, we have three newer drugs for SLE. One is against which have protective for active lupus nephritis, that is belimumab. Then for non-renal lupus, we can add anifrolumab, that is an interferon 1 receptor agonist, that is anifrolumab. Then we have a calcineurin inhibitor for active lupus nephritis, that is voclosporin. So we have two for active lupus nephritis, one is a voclosporin and another is a belimumab. And for the non-renal lupus, we have a anifrolumab. For systemic sclerosis, we have interleukin 6 inhibitor, that is tocilizumab. It slows the decline of pulmonary function. And we have azathioprine that can be additionally given for systemic sclerosis associated with lung disease. For diabetic nephropathy, it is favorable to add a mineralocorticoid receptor antagonist as it reduces the blood pressure, it reduces the proteinuria. A patient with IgA nephropathy, SGLT2 inhibitors can be added. For pseudotumor cerebri, weight loss is very, very important. You can go for a bariatric surgery to reduce the intracranial pressure. For muscular dystrophies, we have a newer drug for the DMD, that is casimersen. For metastatic intracranial tumors, we have a mementamine 5 mg once daily can be given. For transient ischemic attacks, we can give dual antiplatelets aspirin with clopidogrel for the 90 days. Left atrial appendage is a source of embolism, so percutaneous left atrial appendage closure can also be done when the anticoagulation cannot be done. For the psychosexual disorders, that is for the hypoactive sexual desire disorders in a premenopausal women, you can as a bremelanotide can be added. And for the trauma and stress related disorders, that is anti-ecstasy drug, you can add a MDMA, that is methyl methamphetamine can be added. And Canada has recently made it available over the counter. For high LDL cholesterol, earlier we have seen that you can add PCSK9 inhibitors, that was evolocumab, and now we have a PCSK9 inhibitor that uses RNA silencing technology known as inclisiran. It can be given twice yearly dosing. For obesity, GLP-1 agonist can be given, semaglutide can be given. Now we have infectious diseases. So earlier it was seen that for febrile neutropenia, the antibiotics was given for a much longer period. But now, if the patient has become afebrile in the 72 hours, that is 3 days, antibiotics could be discontinued. What are the antibiotics we can give? We can give imipenem, we can give meropenem, we can give tobramycin. Along with these, you have to add for the gram negative, you can add a fluoroquinolone, ciprofloxacin. You also have to add an antifungal, so add a voriconazole or caspofungin and continue for 5 to 7 days. Now, earlier what was that if the CD4 count is less than 50, so you have to add a prophylaxis against MAC. But now it has been discontinued, you need not add a prophylaxis against MAC. Now FDA has approved a newer drug for the pre-exposure prophylaxis in the injectable form that has to be given every 8 weeks, that is every 2 months, and that is cabotegravir. In poliomyelitis, there is a new oral polio vaccine type 2 has been developed, and for the type 2 polio virus outbreaks. For tick-borne encephalitis, there is a newer vaccine, Ticovac. For African trypanosomiasis sleeping sickness, first line FDA approved, that is fexinidazole. For leishmaniasis, we can add-on drug can be a miltefosine. For candidiasis, there is a newer drug developed, that is a glucan synthase inhibitor to treat a vulvovaginal candidiasis. This is Ibrixa fungerap. So fungal, last word is fungal, and then the Ibraxa. It is a glucan synthase inhibitor. Then for marijuana toxicity, you can add a cannabidiol. They constitute cannabis that does not produce THC like intoxication. It is also anti-inflammatory, antioxidant, and anxiolytic. For theophylline or caffeine toxicity, hemodialysis can be done, and nowadays ECMO has been approved for the same. For bronchogenic carcinoma, two drugs have been approved. One is sotatercept and other is atezolizumab. And for stage 3 non-small cell carcinoma, durvalumab has been approved. For bladder cancer, we have pembrolizumab, nivolumab. For urothelial carcinoma, For metastatic urothelial carcinoma, we have erdafitinib, and first antibody drug conjugate approved for advanced and metastatic urothelial carcinoma is N42MAP. For diphtherian contractures, percutaneous needle aponeurotomy can be done. For low back pain, for the short-term treatment, we should go for the heat treatment. You can also go for the spinal manipulation and acupuncture. You can go for the intra-articular steroid injections or cooled radiofrequency ablation of a sacral lateral branch nerves and a dorsal ramus of L5. You can also go for a thermal radiofrequency ablation. So for low back pain, we have heat, spinal manipulation, acupuncture, intra-articular steroidal injections. Then we have sacral lateral branch, and then we have a thermal radiofrequency ablation. Sexual, gender, and minority health. We have a health care for lesbians and bisexual women. You have to increase their self-esteem. You have to give them a social support. You have to see what resilience they are facing from the social groups. Better reproductive outcomes has been seen with in vitro fertilization. However, both the partners of the couple need to be willing to participate in a reciprocal IVF.